Your partner has left for a conference and you're the on call surgeon. The nurse calls you because one of his post surgical patients is complaining of some drainage from his midline laparotomy wound. He's afebrile, he's not tachycardic, and is normotensive. What would you like to do?
Before I go see the patient, I'd of course like to know why the patient had surgery and what operation he had. If possible, I'd try to contact my partner on the phone. If he's not available, I would review the chart, including the operative report.
Okay, you're able to get your partner on the phone. The patient presented with an adhesive small bowel obstruction about 10 days ago. He had an open appendectomy prior to that. He has a history of hypertension and is a smoker. He failed conservative management for the small bowel obstruction and was taken to the operating room several days later. Your partner says there was a significant number of adhesions and it took him nearly 4 hours to get to the point of obstruction. He decided to perform a small bowel resection of the obstructed segment with a primary anastomosis. The patient is now post-op day 7 from that operation. What would you do next?
Well, given the length of the operation and the significant adhesiolysis that was required, there's several different post-surgical complications that would concern me, including a missed enterotomy, a thermal injury, an anastomotic leak, fascial dehiscence, or any kind of surgical site infection. I would start by reviewing the patient's labs from this morning. I'd pay close attention to his white blood cell count, and I'd go see the patient and perform a physical exam, specifically of the abdomen and the surgical wound.
The white blood cell count is elevated to 14, which has trended up the last few days. The rest of his labs are unremarkable. The abdomen is soft, and you notice a brown, yellow colored fluid emanating from the bottom of the wound. There's no significant erythema around the skin, and it's only mildly tender to palpation. What next?
I would open up the incision to look for any kind of purulent drainage, anything that looks like succus or fascial dehiscence.
The wound is opened. The fascia appears to be intact. There's no purulent fluid, but you still see brown, yellow colored fluid seeping out, which smells quite foul. What next?
Given that the patient is stable and has a otherwise relatively benign physical exam, I'd start with a CT scan with oral and IV contrast. Considering my differential at this time, and make sure that the patient has 2 large bore peripheral IVs, in case at any point the patient was to become septic appearing and require resuscitation.
The patient goes down for a CT scan, which shows an intact anastomosis, a 5 centimeter rim enhancing fluid collection in the pelvis, and in the mid abdomen, there's a connection between the bowel and the surgical wound. How would you like to proceed?
So those radiographic findings are suggestive of an intercutaneous fistula. Unfortunately, this may have resulted from some kind of missed injury during the adhesiolysis. Now that it's post-op day 7, though, I'm a little bit nervous to go back into that abdomen, which would honestly possibly cause more harm and more enterotomies. So I think at this point, the best course of management would be non-operative management, especially considering that the patient otherwise looks so clinically well. The principles of management at this point are to control intra-abdominal sepsis with source control, optimize a patient's nutrition, provide excellent and around-the-clock local wound care, and then give this fistula a chance to heal on its own. This is likely best done by engaging a multidisciplinary team, so that includes a dietitian, a nutritionist, and an experienced wound care nurse. Given the pelvic abscess on CT, I would like to start antibiotics and consult my interventional radiology colleagues for placement of a percutaneous drain. I'd like to send the fluid for culture. For the first day or 2, I would continue to trend his white blood cell count, his lactate, and perform serial abdominal exams to ensure that the patient is moving in the right direction.
This scenario started with very limited information provided to the candidate. All that was described was a potential complication for another surgeon's patient. This could be your partner, this could be a surgeon from another hospital or another group. It doesn't matter. What matters is you approach it the same way, which should involve getting as much information as possible by reviewing the chart and operative report, or requesting records from another hospital, and most importantly, finding that surgeon and speaking with them. That makes sense, right? Because that's what you would do in real life. So don't get stumbled on the boards when they present a patient in this manner. And the case could be about any postoperative complication. This one was about an enterocutaneous fistula. If you're given a wound that drains fluid several days after surgery, there's only a couple things it could be. The differential would be a missed enterotomy, a thermal injury, a leak from the anastomosis if there was one, fascial dehiscence, an intra-abdominal abscess, or a surgical site infection. For all of these complications in a stable patient, the next step would be a CT scan. If the CT scan is consistent with an enterocutaneous fistula, you have to decide if you're going to fix it then and there.